ahead, just push the down button.
Okay, thanks everyone. It's nice to be here. I am the Residency Program Director at the University of South Florida program, which is 100% based at the Moffitt Cancer Center. I have no disclosures. There's a lot of talk in the literature these days about next generation academic medicine. We have to cope with a lot of policy shifts. There's population health changes, global budget, value-based purchasing, outcomes measurements. These are all things that we're concerning ourselves with. And then you have to add in things like CPOE, EMRs, ICD-10, and new billing rules, and you throw this all together, and it gets very complicated. And so this makes the old way of doing medicine no longer effective. We used to be individual doctors working in an office, seeing a patient. It's sort of you and the patient, and you write whatever note you do, and then the billing just kind of happened, and that was the old way of doing things. And now, particularly in oncology, we work in teams. We work with our medical oncology and surgical colleagues. We have a lot of academic appointments across the institution, working in different committees in academic ways with people with a variety of different approaches. So this lone healer concept, or these individuals as healers, is gone away. So we have this changing medical landscape. We need to change from thinking about an individual patient to doing a systems-wide view across a whole hospital or institution or series of hospitals as a 360-degree physician leading a medical team. And the DNA of a physician, it does not automatically translate into them being a good leader. But physicians are often placed in leadership positions by virtue of their academic accomplishment. Well, he's the full professor, so he's going to lead the committee on whatever. And it's not necessarily related to their leadership competency per se. There's concepts, obviously, of emotional intelligence. It's critical for healthcare leaders to have leadership competency for physicians. It's in fact important in the boardroom, the chairperson's office, the ward, the bedside. Emotional intelligence has 12 different elements in 4 main domains that are circled there. For time, I can't go into all of this. But what can we learn from business, where people have researched these things? So David McClellan from Harvard has shown that leaders with strengths in 6 or more EI competencies were more effective than their peers. An example is a global food company where among leaders with high emotional intelligence, and there are tests one can do to quantify it, 87% were in the top third for annual bonuses, and those leaders outperformed their peers by 15 to 20%. So how do we do that in healthcare? At the University of South Florida, and we sit on their campus, though Moffitt is not actually formally USF. We just have a relationship with them. The former Dean Klasko, felt that we saw a higher rate of leadership failure in medicine because leadership selection doesn't as strongly consider qualities that business embraces, like emotional intelligence. So he and others said, what if we took some of these leadership training ideas and applied them into medicine? And what emerged from this was something that I believe is unique in the country at the University of South Florida. They have this so-called SELECT program, Scholarly Excellence, Leadership Experiences, Collaborative Training. And he worked with folks from there, as well as the Lehigh Valley Health Network in Pennsylvania and the Telios Leadership Institute, and created a 4-year longitudinal experience for medical students. The way that it works, just in case you want to know, is that a student applying to the medical school can say, I want to be in the traditional class or be considered for the select class, or either, or both. And so when the students go through interviews, when they're interviewing, the select students have a standardized interview process that they all go through, and it's the same for all of them. And they somehow rank or score them using some proprietary method that is elusive to me. I don't know how it works. But in essence, the idea is that they're admitted to the medical school based on emotional intelligence and not necessarily by MCAT score. Obviously, it needs to meet certain minima, but they're not necessarily the highest MCAT scores. So how do we do this in radiation oncology? we need to demonstrate these elements of leadership in practice, and there have been publications about this. So since we are focused or located at the University of South Florida, the idea was that we could leverage this program for our residents. There are two full-time faculty members in the medical school. Dion Jones is a JD as well as a PhD in education, and Joanne Quinn is a PhD and an MBA in management. It turns out that there are MDs in this program, and one of the directors of the program is our own department, Sarah Hoff, who is a GI radiation oncologist. So she works 1 day a week fully in the medical school working with these people. So the idea was that we would create a 1-year mini curriculum, and our intent, and it's starting this year, is to do a pre and post testing using validated instruments of the ESSGI and the TKI. The ESSGI is the Emotional and Social Competence Inventory, and it's a 360-degree survey that collects EI ratings. It requires training to administer it and grade it, and it turns out that one of those individuals from the medical school is competent to deliver that test. And then there's the TKI, the Thomas Kilmann Conflict Mode Instrument, and it's considered the world's best-selling instrument for conflict resolution. And so beginning somewhere around July, August of this year, we're fleshing out the schedule now. The residents will go through pre-testing using these two instruments, and then go through a curriculum longitudinally across a year. It will utilize a number of lectures that the medical students in the SELECT program get, sort of a distillation of them. They have a 4-year longitudinal experience in weekly lectures in didactics and Socratic teachings and exercises, and a capstone project they do. And we can't quite encapsulate all of that. But we'll be doing probably, we estimate, about an hour every other week on average across this next year. And then the residents will also then be subsequently post-tested as well to see any changes that occur. And we can formally expand it depending upon the initial results, and even consider subsequent expansion to other radiation oncology programs. So that's kind of where our thinking is right now. So I'm getting us back on track because I am done. Do you have any questions?